Assalamu alaikum, it's Dr. Nas, and today we are here with a new topic of cardiology, which is actually have a very difficult concepts to understand. That's why I just wanted to make it very simple, very easy for you guys. So I will try my level best, because you know that the tachyarrhythmias is the crux, is the pivotal chapter. And the if you don't know about the tachyarrhythmias, you will never be a good cardiologist. So without wasting time, we will move towards our topic. So today we will focus the basics of tachyarrhythmias. Actually, what is the pathophysiology behind the tachyarrhythmias? What is because you know that without understanding the normal electrophysiological system of the heart, you cannot understand the tachyarrhythmias and the pathophysiology behind the tachyarrhythmias. That's why we just discuss briefly the basics of the electrophysiology of the heart, and then we will move towards the normal action potential going on in the cardiac muscle, and the drugs which we used as a anti-arrhythmics, which are actually anti-arrhythmic as well as the pro-arrhythmic. That's why their usage is limited in so many places. That's why. And the pathophysiology of the tachyarrhythmias. So you know that anything, what is normal, what is a normal heart rate, what is a normal rhythm. So the normal rhythm is that rhythm which have a heart rate of around 50 to 100. It should be more than 50, and it should be less than 100, and it should pass through a normal pathway. We will discuss later on that what is the normal pathway of the heart for the cardiac impulses, and it should have to pass with the normal velocity. It should not pass like with the decreased velocity or increased velocity. So anything which is going down the 50 and above the 100 heart rate, it could be abnormal. Anything which is passing through the abnormal pathways, it could be abnormal. And any impulse which is going slower and the faster in the cardiac muscle, it might or it could be what we say that abnormal. So first of all, we have to discuss about the normal pathway of the heart. So you know that the SA node is present at the right side beneath the superior vena cava, and then from that SA node, actually the impulse is transmitted to the AV node via usually by the atrial tissue, but there are three main fibers as well. One is the anterior intranodal fiber, second is mid intranodal fiber, and third one is the posterior intranodal fiber. So these actually fibers are responsible to transmit the impulse from SA node to AV node, but these fibers are not whole and sole responsible for this activity, because atrial tissue has also a capability of propagation of impulse. That's why it also propagates the impulse through the atrial tissue as well. And there is an other like fiber which can transmit the impulse from right atrium to the left atrium. Then after coming from SA, then this impulse reaches here, that the AV node, okay, and then from AV node it goes down to the bundle of His, and then this bundle of His then divided into two bundle branches. One is the left bundle branch, and second is the right bundle branch. And then left bundle branch further divides into two fascicles. One is the left fascicle, and other one is the it is this left anterior fascicle and posterior fascicle, and right bundle branch is it's just continued in the right fascicles, okay. So as we have discussed that anything which hurdles the cardiac impulse in the cardiac tissue causes abnormality. Anything which moves this cardiac impulse from its normal or natural pathway, or like its native pathway, then it moves that impulse towards any accessory pathway, like any other scar or any other arrhythmogenic tissue, then it gives us the tachyarrhythmia. tachyarrhythmias. We will discuss right now that how these tachyarrhythmias occurs. But before going towards the pathophysiology of the tachyarrhythmias, we need to understand that how cardiac impulse generated, how our heart contracts, how the impulse propagates in our heart from sinus node to the fascicles. So you should know that there is action potential of in any muscle, in any muscle of our like any tissue which has a conduction quality in our body has the action potential, but the action potential of the heart is is bit different from the action potential of brain, nerves, muscles, okay, skeletal muscles. So here in cardiac muscles, the most of the time your cardiac tissue has the resting membrane potential of less than 80 or minus 90. So anything on below 90, it should be in absolute refractory period. So you have to do something to make it bit positive, to generate an impulse. For that thing, nature does that. Nature gave us sodium channels, okay, sodium gated channels. Whenever there would be a there would be an opening of the sodium gated channels, then the positivity increases. As you know that the sodium is a positive channel, and why sodium goes inside to the this cell. So you should know, I think you should have known the concept of voltage gated channels, the passive movement of channels and the active movements of channels. Passive movements of channels occurs when there would be a higher concentration, when these ions should be moving from higher concentration toward the lower concentration. But the voltage gated channels are so of the channels which can exchange and through which actually works on the ATP, and also as well as dependent on other ions to go out and they have to come in. But when sodium gated channels open, then the resting membrane potential becomes positive. When it becomes positive, it goes up. When it crosses the 80, then the action potential occurs and your membrane depolarizes. When it depolarizes, then this is actually 0 is the first stage of the action potential. First stage 0 is the initial stage, and the initial positivity becoming the positivity of the membrane, which causes the action potential when the sodium gated channel opens. When it opens, cardiac muscle depolarizes, then it goes up to the plus 30 and the plus 35. Then the voltage gated calcium channel opens. When the calcium channel opens, then the efflux of the potassium and the influx of calcium. So the efflux, because you know that cells are nothing but the sacs, or the shoppers and the bags and the sacs of potassium ions. So whenever there would be an exchange of sodium or potassium, or when potassium would be going out through its channel, then there would be a balance of influx of calcium and efflux of potassium. You know that potassium is also positive ion and calcium is also positive ion. So when the out of the potassium and inward of and then efflux of the potassium and the influx of calcium balances each other, then you will find a plateau over here. Plateau means the activity remain static and it goes static, because this bar shows the time and this vertical bar shows the millivolt. Then you see that here is no change of the millivolt, because the efflux of the potassium and the influx of the calcium is almost balancing each other. Okay, when there would be closing of like this a calcium channel, but there would still be a efflux of potassium, then this slope goes down. Then the zero would be because of the sodium channels. Because of the influx of the sodium channels, membrane depolarizes, then efflux of the potassium and influx of the calcium causes plateau, which would called as here sodium channel closes. Actually, whenever sodium channel closes, then the calcium channel opens and the potassium channel opens, and the efflux of the potassium as well as the influx of the calcium occurs, which causes the which causes to stage 2 of the action potential, which is known as the plateau. Plateau means static, plateau means straight. Okay, so you know, and you can appreciate that there is no change, there is no transition of the millivolt over here, but just the time is elapsing because of calcium is going in, and potassium is going out. When here at the stage 3 this potassium channels open, and these are the actually slow potassium channels. When it opens, then the calcium channel closes. When the influx of the calcium closes but the efflux of the potassium continues, then what happens? Then this like this depolarization, and this very positive of the membrane is now going back towards the negativity. So this going back towards the negativity and efflux of the potassium called as repolarization. So this stage which you can appreciate here is the 3, because of potassium is going out and the calcium channel has been closed. Then repolarization of the membrane, repolarization of the cardiac tissue is occurring, and these are the actually stages where we will discuss about the one of the pathophysiology of the tachyarrhythmias is triggered activity, in which there is a early after depolarization and here is a delayed after depolarization. So we will discuss later on about it, but just focus here that anything because of the repolarization. And why repolarization occurs? It occurs because calcium channels has been closed. Now potassium is going out through the slow potassium channels. Then the repolarization of the cardiac muscle occurs, and it going down, going out until it reaches the resting membrane potential, and again your cardiac membrane, your cardiac tissue get repolarized and again will go into the resting membrane potential and reaches here stage 4. So the resting membrane potential is a stage 4 is actually then the depolarization, then the closing of the sodium channels, and here is then the plateau, and there is a repolarization, and then again going towards the resting membrane potential. So any drug we will discuss later on about these von Wegans. This is actually the old classification we will discuss later on here, because the newer one is a bit complicated, and I don't think so if I will discuss that classification over here, then you will be bit confused, because you have to make your concepts about the tachyarrhythmias. So what is the pathophysiology? There are so many pathophysiology, but the main 3 pathophysiologies behind this tachyarrhythmias are automaticity, triggered, and the reentrant. You know that the automaticity only causes less than 10% of the tachyarrhythmias. Why it occurs? Why your membrane becomes automatic? Because as I told you that anything which make this membrane bit positive, then this membrane reaches near to the action potential. You have to make it bit positive to make it to make it depolarizes. So when there would be a leaky sodium gated channels, here automaticity occur because of the leaky sodium channels, leaky voltage gated sodium channels. When there would be a leaky sodium gated channels, and why these sodium gated channels becomes leaked, these this may be this may be because of ischemia, because or any injury to the heart which makes it more arrhythmogenic. So it actually, why it makes it more arrhythmogenic? Because it is making the sodium channel leaked. So it is making the leaking of the sodium channel. So when there would be a leaking of the sodium channel, then persistently sodium is going inwards the cell and making it more positive. When this membrane of your cardiac cell would be more positive, or it is near to the action potential, or it is near to that range where this action potential or the depolarization occurs, then anything which goes inside, because membrane is already near to the action potential, it goes up. So this automaticity occurs because of the leaky sodium channels, because leaky sodium channel make it this membrane more positive, like over here. Then anything which goes inside, which is positive, causes the action potential of the cardiac membrane, and causes the cardiac impulse to occur. So that's why all tachyarrhythmias are the pathophysiology behind the all tachyarrhythmias caused by automaticity is actually the leaky sodium gated channels. So the examples of the automaticity are the very example in the ventricles are the accelerated idioventricular rhythm and the multifocal atrial tachycardias. So these are the very good examples of the automaticity in our heart. Then again, the one more thing which I actually want to discuss over here is the triggered activity. So actually the most common cause of the tachyarrhythmias in our heart is reentrant tachycardias. But what is the first we will discuss about the triggered, and then we will discuss about this reentrant tachycardias. What is the triggered? So anything which triggered the heart to make an more impulse here after depolarization. So here the depolarization and the plateau. After plateau, depolarization almost completes, after plateau most of the time depolarization completed. So after the completion of the depolarization, if any impulse or any activity or any arrhythmia comes at the stage here, most of the time it would be early after depolarization. And why it occurs? Because here almost you have crossed your absolute refractory period. Now you are moving to sorry, here your muscle is almost in absolute refractory period, but it generates the impulse through an other like mechanism. So any your arrhythmia which comes after depolarization, after the plateau, but it comes earlier to repolarization, then you would say that it is a early after depolarization. We are not going like much deeper into it, because it will make us confused. Just remember that any arrhythmia which comes after depolarization but before repolarization is early after depolarization. And EADs, the most common cause of the early after depolarization are the long QT, or the drugs which are causing the long QT syndrome, and the or any condition which is actually causing the long QT syndromes, torsades, magnesium deficiency, or any drug which actually cause the torsades. So the torsades and the long QT syndromes are the best examples of the early after depolarization. But anything which, when there would be repolarize, when the muscle completes is completing its repolarization, but just before it coming to the resting membrane potential, delayed after depolarization occurs. And this delayed after depolarization again occurs because of the digoxin toxicity and CPVT. We are again not going towards the molecular basics of these both things, because it would make you confused here, but just remember the two things for your examinations and for your basic concepts, that the early after is after the plateau, and delayed after is after the repolarization. depolarization. So the early after depolarization is actually before the repolarization, and the delayed after depolarization is actually after the repolarization. So these are the two stages of the EADs and the DEADs. Okay. Now the most important thing which I want to discuss over with you guys is the reentrant tachycardias, and we will discuss it later on, like its type, AVNRT, long RP tachycardia, short RP tachycardia, flutters and all these things. But just remember one thing over here, that how it works, how it happens actually. So in your keep remember the criteria for the reentrant tachycardias. To reentrant tachycardias to be occur in our body, you should have a few things in your body. One, two distinct pathways with the two distinct refractory periods. If you would not have a two distinct pathways with the two different refractory periods, you will not make your heart to be reentrant tachycardic. Okay. So for this reentrant tachycardia, you must have two things. One, two different pathways with the two different refractory periods, and one trigger which actually causes the to pass the impulse through another pathway when the other one would be like in the refractory period. So before discussing anything, we have to I just want to make you understand about this thing. So here appreciate that there are the two distinct pathways. One is the red marker, the line which I have marked with the red, and other is the blue. The red one is fast pathway, but it has a long refractory period. So always when there would be a fast pathway, then its refractory period would be longer, and when there would be a slow pathway, then its refractory period would be shorter. Okay. So now it's very important concept to understand for you guys. That is the basic reason to causes the to make a circuit to cause the reentrant tachycardia, how its circuit works, how its circuit becomes active. When there would be any triggered activity, when there would be any triggered activity from like from atrias or from ventricles, then you know that because that the fast pathway has a long refractory period, then it would remain into the refractory period. So impulse cannot go down. Impulse cannot go down through the red marker, because this fast pathway has a long refractory period. Then this impulse goes down through the blue marker, through the slow pathway, because it has a short refractory period. When it goes down, because it has a long refractory pathway, when it goes down here, then obviously up to the here, then it goes like it goes out, it gets out from its refractory period. Then this impulse actually activates the ventricles and goes here to make the circuit. Then when it goes here, it again activates the fast pathway, and you know that the fast pathway is again then it moves retrograde towards here, and then and you know that the fast pathway has a fast impulse but the long refractory period. Then again it goes down because it has a short refractory period. Then when it goes up and down, then again this pathway would be into the refractory period, and this impulse again goes down through the slow pathway. Then again and again this impulse moves into the circuit, and it actually makes a circuit to cause the arrhythmia. Then this again activates the ventricles and goes upward, make a circuit, and then again it would be into the refractory period, and it would be out from the refractory period. Then it again goes to this slow pathway, and then when again activate the ventricle, then your arrhythmia occurs, and your heart becomes tachyarrhythmic. So this is a very basic concept to understand the reentrant circuit. Then what you have to do, you have to do something, you have to interrupt the circuit, you have to stop the heart for the time being, you have to do something, you have to block the atrioventricle, you have to block the circuit. So to block the circuit you have to do something. So whenever you would just block the circuit, heart would be normal and heart would comes into the normal rhythm. That's why we just do the DC cardioversions and the different drugs which we will discuss in our later lectures about. We will discuss one by one all tachyarrhythmias, like narrow-complex tachycardias and the regular narrow-complex tachycardias. In regular narrow-complex tachycardias, we will discuss the AVNRT, AVRT, the short RP tachycardias, long RP tachycardias. Then we will discuss the flutters, the typical flutter, atypical flutters. Then we will discuss the atrial tachyarrhythmias. Okay, so here I just want to add one thing after this anti-arrhythmic classification, and just keep one thing, remember that these anti-arrhythmics are pro-arrhythmic. These anti-arrhythmics are pro-arrhythmic. That's why we have to use it very cautiously in our patients. That's why no one but cardiologists can only use it. Okay, so here I hope that you have you have understood this very basic concept of this. So just I want to discuss few things over here, that sinus tachycardias. There are two types of sinus tachycardias. One is appropriate sinus tachycardias and second is inappropriate SIN tachycardias. Sinus inappropriate tachycardias. Okay, inappropriate tachycardias. So anything above the 100 is sinus, when it is in the sinus rhythm, it is coming from the sinus, going through the normal pathway, but it's going fast. It's going fast, and your rhythm is faster than the normal. Then you have to check it, that is it the sinus or not. If it is sinus rhythm, then you have to divide it or categorize, or you have to categorize it into two things. One is appropriate sinus tachycardia, second is inappropriate sinus tachycardia. The appropriate tachycardias are those tachycardias which have a secondary reasons, like your patient has a fever, your patient has acute illness, your patient is in shock, your patient is in failure, your patient is like any cause which is appropriate because of the sinus tachycardia comes under the domain of the appropriate tachycardias. But inappropriate is like your patient has nothing, but your patient still has the sinus tachycardia. Then you have to treat it. Obviously, you have to treat it with the beta blockers and the AV nodal agents. Like if your patient still has the sinus tachycardia, then you need to have the study, or like you need to have the EP study for this, and you have to treat it appropriately. Like this. Okay, and the ultimate, if you have, despite of giving the medical therapy, you can do the catheter ablation on your patient with the sinus tachycardia, inappropriate sinus tachycardias. Okay, so this was the one of the cause of the tachycardia which I wanted to discuss over here, but the other things we will discuss in detail. So before winding up this lecture, I just want to discuss these anti-arrhythmic drugs with you guys. You know that there was a stage 1 which was dependent on the sodium gated channels. That's why in this anti-arrhythmic classification we have a sodium channel blockers. It has three classes. It has three groups. Class 1 anti-arrhythmic has three groups. One is 1A, 1B and the 1C. So 1A consists of the quinidine, procainamide and disopyramide. I am repeating it. 1A, the sodium channel blocker class 1A consists of the three drugs. There are so many drugs, but the popular one are these three drugs, like the quinidine, procainamide and disopyramide. And class 1B are lidocaine, mexiletine and phenytoin. Yes, phenytoin, miglutatine, and lidocaine. Okay, so one drugs like 1A has 3 drugs. What are those? Quinidine, procainamide, and disopramide. Number 1B has 3 drugs again: phenytoin, procainamide, and miglutatine, and 1C drugs, which are actually most common and the very favorite of our teacher, Dr. Zai Jamal. These are flecainide, propafenone, and yes. So these are the drugs actually, flecainide and the propafenone. And then class 2 has the beta blockers. You know that class 2, stage 2 is because of the calcium, is because of the calcium channels which actually were causing the plateau. So you know that when you will decrease the sympathetic activity, you are actually decreasing the calcium into the heart, which actually decreases the sympathetic and increases the parasympathetic. That's why this is the beta blockers. And number 3 are you know that after the plateau there were the stage 3 of the action potential. Then here we have a stage 3 drugs. These are the potassium channel drugs, because there was the efflux of the potassium which were actually causing the repolarization. So here we have drugs like abutolite, sotalolol, dronidrone, dofetilide, and amiodarone. Okay, so these are the drugs which are which come into the domain of this stage 3 drugs. And number 4 drugs are the calcium channel agonist, antagonists like verapamil and diltiazem. So this was a simplified von Wegen's anti-arrhythmic classification. Now since 2018 we have a new classification of this anti-arrhythmic drugs, but that is actually, I told you, the very complicated. That's why I would suggest you guys to please go through once through this classification and just like keep remember few things about it. Okay, I am not going to discuss that classification over here. You can find easily on the up-to-date on the and on internet of this classification. In our next lecture we will discuss the long RP and the short RP tachycardias, and then after that we will discuss the atrial flutters, and then the atrial tachycardias, and after that we will discuss the WPW and the pre-excitation syndrome, and then we will move towards the regular white complex tachycardias and VT, obviously the causes of VT and all these things. And after all that we will move towards the atrial fibrillation, because you know that the ride of the tachyarrhythmias would be rough, would be difficult. You have to be with me, and you have to after watching the lectures, you have to watch it again and again, just to keep remember, or just to keep memorizing these things, just to memorize these things. And you have to read through, and you have to go through your box, you have to go through your notebooks, and the one thing which I actually want to suggest you guys, that jot down the major points from this board and from my lecture or from your books, and make some notes somewhere, because when at the end of these all sessions, and when your time would be near for the exams, you have that notebook would actually be very helpful for you guys. So take care, subscribe my channel, and press the bell button for the future updates, because you have, after tachyarrhythmias we will move towards another topic. So please be with me, pray for me. We are just doing this for you guys. Okay, so appreciate it, enjoy it, and study hard, work hard. Take care. Allah Hafiz.